So, very good evening, one and all. Very good evening, seniors, juniors, my fellow doctors and peers. It's always a pleasure to catch up for an academic feast and a discussion to follow. Uh, as we all know from our clinical practice, India is a country with a huge metabolic syndrome burden. We have the ICMR INDIB 17 study, which was just published in 2023, showed that we already have more than 315 million hypertensives in India. Not just that being complicated with, again, more than 100 million plus patients with diabetes, 136 million patients with pre-diabetes, a good number of patients with obesity, and an overall metabolic syndrome cluster. Uh, from a hidden perspective, a lot of our Indian patients, 70% of patients with type 2 diabetes tend to have associated MAS LD, metabolic associated fatty liver disease. What about the cardiovascular risk continuum? We Indians tend to develop cardiovascular events at least 10 years before our Caucasian counterparts. And our experts might say that's even much earlier compared to our Caucasian counterparts as far as latest evidence is concerned. So, one important fulcrum in this entire parameter tends to be hypertension and the fact that it is associated with clustering of cardiovascular risk factors and metabolic syndrome in the Indian scenario. To discuss more and delve into perspectives of the same, we have with us our esteemed panel today, and I have the honor of introducing each of our esteemed faculty. So, next. At first, we have Dr. Arup Das Biswas, sir, who is the Emeritus Professor of Cardiology at PKG Medical College and Hospital, a consultant interventional cardiologist at multiple reputed hospitals in Kolkata. He's also conducted and been part of multiple clinical trials and registries with multiple publications in national as well as international peer-reviewed index journals. He is an ex-examiner. He's been an examiner to the DM and the DNB cardiology educational scenario, and has also been a regional faculty at PHFI and a referee to the Indian Heart Journal. He's also been a thesis adjudicator and life member in the Indian Science Congress. Next. We will have with us Professor Dr. Arun Kochar, who will join us very soon. Sir is a senior consultant interventional cardiologist at Fortis Hospital, Mohali, with over 24 years of experience and 100,000 procedures till date. So his area of expertise includes radial interventions, nuclear cardiology, and preventive cardiology. He's also been a chairperson of the prestigious annual Congress of the CSI and the Asia Pacific Cardiology Congress. He's also been a principal investigator in many phase 3 international trials and has numerous publications to his credit in peer-reviewed index journals. Next. We also have Dr. Amit Satur, a very talented and interventional cardiologist whom we've met in the past too. And I have the honor to introduce him too. Sir is an interventional cardiologist and the director of the cath lab at Suchirayu Hospital. He's also been the secretary of the Northwest Cardiology Society of India, and he's completed his advanced interventional cardiology training at the reputed Mayo Clinic in Arizona, USA. He's completed the first successful full body 3D MRI compatible AICD implantation in North Karnataka, and was also one of Times of India Achievers of Karnataka Award in the field of medicine in 2022. With this eminent faculty, I now hand over to our speaker for the day, Professor Dr. Arup Biswas. Sir, over to you.
So Dr. Satur is going to make any statement, or should I go to the...
No, sir. So you can present right now. And Dr. Satur would join in as an esteemed panelist.
So I'm going to share the slides. Give me 2 minutes.
Yes.
some problem happened. Both my files were deleted.
Team
Someone
DocMode,
from your side can share the slides?
Team DocMode, can you help with sharing Dr. Das Biswas' slides? Will be very kind of you.
Yeah, sure. Vinay can help it out. Vinay?
Because it will take some time if I go to the mail and again download.
Sure.
Yeah.
Yes. Tim, can you please share the slides with us on our mail ID?
If it takes time, I'll try.
So, dear audience, as as we find ways to share the slides soon, which will be done, just minor technical glitches. But what we would encourage each and every one of you is probably you could uh, decipher or share your journey with uh, interesting challenges or interesting cases in hypertension that you've seen, which you could probably share across as a query. So meanwhile, until all that is getting done, we can also uh, probably, take that a little ahead.
Is somebody doing it?
Team DocMode, somebody sharing?
Yes, sir. Yes,
Yeah.
sir. Yeah, sure.
Yeah.
In the meantime, Dr. Muralidharan, just
Sure.
since you were, okay, this started. Yeah.
Just come. So everybody can see it now?
Yes, sir.
Yes, sir,
Okay.
we can.
Only disturbing point will be that I'll have to say next slide like this.
That's completely fine. That's completely fine.
Okay. So, good evening, everyone. Thank you for everybody for being present. Sorry for the initial glitch that took some time. I'm sorry for the delay. Now, the tune of the talk has already been set by Dr. Parth Sarthi, and beautifully so. So, what I'll be doing in my presentation is that I'll be trying to set how to approach hypertension management when a patient is having metabolic syndrome. So that is being titled as precision approach. Now, already it has been said that when it is a combination of metabolic syndrome along with hypertension, it is a very dreadful situation for atherosclerosis, coronary artery disease, stroke, etc. And also, hypertension is commoner and often a component of metabolic syndrome. Next slide. So if we look into even lay journals, what I find that the incidence and prevalence of hypertension amongst Indians is very common. And different statistics have shown different results from 25 to 35%. At least 1 in 4 Indian adults are diagnosed with hypertension in our country. And 90% of the hypertensive patients are unaware of the condition, untreated, or poorly managed. So poorly managed that only 10%, even though who are receiving treatment, are achieving appropriate control. So major risk factors for hypertension are poor diet, obesity, sedentary lifestyle, chronic stress and digital fatigue, smoking and alcohol. And early detection is critical because pre-hypertension, that means BP above normal, but below 140/90 is also bad. And that has to be addressed primarily through lifestyle modification, and regular blood pressure checks and assessment of other risk factors are essential in this phase. Next. So the topic of our discussion this evening, as already detailed, is hypertension along with metabolic syndrome, and specifically we'll be focusing in the management of hypertension only. So it is a key component of metabolic syndrome, contributing to significantly to increased cardiovascular and metabolic risk. And what is metabolic syndrome? It is a cluster of interrelated metabolic abnormalities that significantly increase the risk of cardiovascular disease, type 2 diabetes, and stroke. And metabolic syndrome, we know, is a constellation of insulin resistance, glucose intolerance, hyperglycemia, obesity, hypertension, dyslipidemia, etc. Next. Age-adjusted prevalence of metabolic syndrome in urban Indian population is approximately 25%. With a higher prevalence in women, they also perform badly with presence of metabolic syndrome compared to men. And in men, it is about 18.5%. So overall, it is 25%. And there is an increasing prevalence with age in both men and women. Next. So we'll be quoting frequently and freely from one seminal paper which was published in this year in JAPI, that is Journal of API. And I was one of the co-author, and I was initiation of the initiating group meeting. I was there. The title is Bridging the Gap, Managing Hypertension in Indian Patients with Metabolic Syndrome. So from this paper, we'll be trying to arrive at certain consensus points. And the aims and objective was to standardize the management of hypertension and metabolic syndrome, ultimately improving patient outcome and reducing the global burden of these conditions. This we discussed at the outset. Yes, both hypertension and metabolic syndrome are common in India, often misdiagnosed or not diagnosed at all, and very poorly managed, and they are very high risk, and often these dysglycemia component or prediabetes component goes into diabetes. So we approached through the modified therapy method. In our initial meeting, we discussed the theoretical points where we had consensus regarding formation of questions. And then these questions were sent to 532 cardiologists, endocrinologists, and physicians across 18 meetings in India, and anonymous electronic voting on consensus statement using 5 points Likert scale was obtained. So this design was there as we knew that often the patient doctors are refraining of giving their opinion. But if they know that there will be anonymous, they frequently give their opinion in a candid manner. Next. And what is the general practice pattern in our country? Next. So if we look into the map, what we find, it is quite prevalent in India, but there is regional variation. If we look into the south, Kerala is the country where metabolic syndrome is the most prevalent, and it reaches approximately 20%. Whereas this is moderate in certain states like Bengal, Maharashtra, Uttar Pradesh, and in certain states like Northeast, Rajasthan, etc., it is lesser. But overall, a country-wise consensus has to be reached, and we have also to find out the missed cases. So hypertension dominates metabolic syndrome components, as we have already discussed. The most prevailing component of metabolic syndrome was hypertension with a prevalence of 48.7. So roughly we can say 50% of the metabolic syndrome patients are affected by hypertension, and that is often not adequately controlled. And this is followed by abdominal obesity, diabetes, and dyslipidemia. Next. So the diagnostic criteria, almost all of us know, but just let us revise. Metabolic syndrome consists of hypertension, but the definition of hypertension, if it Restrictive here is more than or equal to 135/85. Insulin resistance as manifested by glucose intolerance, fasting glucose being more than 100. Low HDL cholesterol, that is less than 40 in men and 50 in women. Visceral obesity, 40 and 35. Indian standards may vary somewhat. High triglyceride level. This is again a peculiarity of metabolic syndrome. It is more than 150. If only 3 factors are present out of these, we call it metabolic syndrome. Next. Next slide, please. So there is an association of hypertension to metabolic syndrome, we know, and the pathophysiological interplay starts from inflammation, the triggering factor being insulin resistance. This enhances sympathetic nervous system activity and promotes renal sodium retention, contributing to elevated blood pressure. Central obesity, that is the waist circumference, increases blood volume and releases inflammatory adipokines, intensifying vascular dysfunction and hypertension. Dyslipidemia again accelerates atherosclerosis, compound cardiovascular disease, and advancing the progression of both hypertension and diabetes. And that leads again to microvascular, not only macrovascular involvement. So just to recapitulate, metabolic syndrome, visceral fat, they release inflammatory factors, activate RAS system, impair blood pressure, and leads to hypertension. Next. Next slide, please. The interaction of these factors form a vicious cycle where metabolic syndrome and hypertension perpetuate each other, increasing the risk of CV disease and type 2 diabetes. And we know that association risk factors is just not additive, they are multiplicative. So whenever the combination exists, they increase the overall risk to a great extent. And in India, the prevalence of hypertension among individuals with metabolic syndrome is approximately 50%, and that was achieved through Delphi consensus. We have discussed Delphi consensus already. That is the methodology of our making this paper headed by Hiremat, Vander, myself, and others. Hence, addressing metabolic syndrome through lifestyle modification and medical management can significantly reduce the incidence and severity of hypertension, improving overall health outcome. Next. Next slide, yes. So coming to the next section, this deals with BP thresholds and therapeutic decision. This may differ a bit from country to country, but India, we have tried to reach the consensus through voting system, but even then, there may be some individual variation, and I have to admit, and so long it is doing good to the patient, we have to accept this. Next. So when to initiate? The effective hypertension management is essential to reduce cardiovascular risk in metabolic syndrome. Early control of hypertension helps prevent complications such as myocardial infarction and stroke. So we have to detect, not only detect, but we have to do it early and also manage quickly in an appropriate fashion. So the treatment objectives are normalize blood pressure, improve metabolic parameters like glucose, lipid profile, etc., and enhance overall quality of life and increase life expectancy. That means we have to focus to each and every risk factor, looking into the diet, reducing body weight, reducing body mass, focusing the abdominal elasticity, obesity, etc. So it's a holistic management of a particular patient. Next. Next slide. Yes. So management of hypertension in metabolic syndrome, the guideline-based recommendation, as I was talking about, the International Society of Hypertension guideline is the initiate pharmacological therapy in patients with BP is 140/90 or above. American Heart Association, they also say recommend antihypertensive drug therapy when non-pharmacological intervention fail. So initially try with non-pharmacological means. If it fails, prefer treatment when the systolic BP is equal to or more 140 and diastolic is equal to or 9 more than 90. American Diabetes Association are a bit more, I mean, stringent, and they advocate for lower BP threshold to initiate treatment with type 2 diabetes because diabetes in itself is a major risk factor for all these problems. Next. So when we took the consensus, it was there that medical management of hypertension in patients with metabolic syndrome should be initiated when systolic BP and diastolic BP are equal to or more than 140 by 90. But when to start is not only important, but where do we have to reach? That is, goal setting is also very much important. Next slide, please. So the treatment goal that has been again agreed upon by different societies in a different with different digits. Indian Society of Hypertension is of the opinion that BP target should be below 130 by 80, and that has a corroboration with 217 ACC-AHA guideline. Whereas the European group are comfortable with below 140 by 90. But here again, we have to be looking into patient profile. It is not always that we have to be very rigid about the digits. We have to look into the patient's tolerance, whether he's frail or not, what is his age, and whether he is symptomatic of lower perfusion, etc. So what is the level of lowering? And at times, though we want to lower it quickly, at times speed of lowering has to be compromised in certain very hypertensive elderly patients. Next slide, yes. So reduce BP to at least 140 by 90 initially, and then if the patient is tolerating, I'm just adding a few points from my own view that if the patient is healthy, young, has got all these problems, and is tolerating blood pressure lowering up to 130 to 120 and below 80, even up to 70, we can lower that further. So it is again has to be specific. But as far as the guideline goes, our guideline means this Delphi guideline by the study is below 140 by 90. Next. Drug-specific management. So choosing drug is also very important. So lowering BP is important. The speed of lowering BP is important. Managing all the risk factors is important. But again, choosing drugs which are beneficial for this type of patient has to be very, very important and has to receive appropriate consideration because we have to look into not only the digit lowering, we have to look into tissue and organ protection and into the outcome data. Next. So let's talk about two important antihypertensive drugs in this group. One is angiotensin 2 receptor blocker, or in short, ARBs, and meta-analysis shows ARBs are more effective than placebo in sustained BP reduction. ARB reduced stroke risk by 21% compared to other antihypertensives in essential. And we all know that ARB is nephroprotective as well. And what about calcium channel blocker, particularly a good calcium channel blocker that's at a long duration of action, like amlodipine? It's safe in elderly patients with large vessel stiffness, effective across all age groups in reducing BP and lowering stroke and CV disease risk. And when further BP reductions needed to achieve strict targets, CCB can be added even in case of heart failure or chronic kidney disease. Now, these two drugs are having such a half-life that they could be jolly well combined for a single day dose in a single pill combination for appropriate BP control for 24 hours, and that has been confirmed by AP. Another good point about amlodipine is that it is again, besides being able to lower BP, is effective again in lowering stroke. So our overall management, if we combine these two drugs, will be protecting the brain, protecting the heart, and protecting the kidney, and also the peripheral vasculature. Next. So there are certain studies, and one study is this: telmisartan and amlodipine single pill combination versus amlodipine monotherapy for superior blood pressure lowering, improved tolerability in patients with uncontrolled hypertension, and the results of the Teamster study done in Denmark. Now, the study design was that they did it 8-week prospective randomized open-label blinded endpoint trial, and the population was 838 patients with uncontrolled hypertension, and they were treated either by this combination or by amlodipine alone. Next. And what was the finding? That when the group of telmisartan 40 and amlodipine 5 or group B of telmisartan 80 and amlodipine were combined, they were much more effective in reducing systolic and diastolic BP compared to amlodipine 5 milligram monotherapy. And BP goal achievement was quite good, both with group A, that means telmisartan 40 and amlodipine 5, and telmisartan 80 with amlodipine 5. So they were achieving, BP goal achieved were in 72 and 75.7% respectively, whereas with amlodipine it was achieved only in 51.9%. You may say, why amlodipine 10 was not tried? Because that produces a lot of side effects like dizziness, constipation, and edema, etc. In fact, peripheral edema is a limiting factor for amlodipine, though it's a very good drug. Switching to a single pill combination of telmisartan 40 by amlo 5 or telmisartan 80 or amlo 5 is a more effective treatment option for uncontrolled BP than increasing the dose of amlodipine to 10 milligram monotherapy, with more patients reaching their BP goals and less side effect of peripheral edema. So this was the conclusion. Next. And combined therapy with telmisartan and amlodipine on blood pressure, echocardiographic parameters is another study, and microalbuminuria in patients with metabolic syndrome. The study number was small, but the parameters that were tested is quite strict. Particularly, the echocardiographic details were very much detailed, including and microalbuminuria was tested in this group. So 64 patients with moderate to severe hypertension and metabolic syndrome were selected, and they received a 12-week treatment as a post and pre and post therapy. So this is a result of combination therapy. What was seen that there was a robust BP reduction from 178 to 128 in systolic and 109 to 80 in diastolic. That means BP goal was achieved with significant, quite significant. And the LV mass reduced. This is a very important information. Just by 12 weeks treatment, we got LV mass regression. Diastolic function improved by all the parameters of echocardiography and Doppler study. And microalbumin reduced from 56 to 35. So this is reducing BP. Ultimately, it will help in stroke reduction. This is improving the cardiac parameters, and this is improving the nephro parameters. And the combination of telmisartan significantly to BP, cardiac function, and kidney function in patients with moderate to severe hypertension and metabolic syndrome. Next slide, please. So the key highlights from these two studies are effectively help this combination is effectively help a high proportion of hypertensive patients to achieve BP target, particularly beneficial for patients who previously failed monotherapy, significant and sustained BP reduction over full 24 hours dosing period, demonstrated notable efficacy in patients with severe hypertension, consistent effectiveness in patients with and without metabolic risk factors, well tolerated across the patient subgroup. And most common adverse event, peripheral edema dizziness, that was reduced because this was a combination. Then side effect profile of the two drugs differ. So they are not additive, whereas the BP lowering effect is additive. And we all know single pill combination is always compliant from the patient's point of view. We are not going to details why the patients are more compliant with SPC. That we can do the discussion if the issue arises. Next. So telmisartan and amlodipine, again, this is a consensus from that study. Telmisartan amlodipine combination should be recommended as first-line treatment for patients with hypertension with metabolic syndrome. Telmisartan is the preferred angiotensin receptor blocker in patients of hypertension with metabolic syndrome. Next. This trial is again just a repetition of those trials I have discussed. So I'm skipping this slide. Next. Now, our study in India that was revealed that when telmisartan versus amlodipine were compared, it is seen that telmisartan was quite effective in BP lowering. So why I am highlighting this issue is that often there is a misconception that telmisartan is a very weak BP lowering agent, whereas amlodipine is a very strong BP lowering agent. It's not the fact. Both are good. And if the two things combine, the combination will be still better. And highest dose telmisartan and amlodipine, there is again systolic and BP. This is a study from another study, and the goal rates achievement is from 66 to 87%. So large number of people achieve their goal with telmisartan and amlodipine combination. Of course, we may have to titrate the dose of telmisartan from 20 to 80 and amlodipine from 2.5 to 10. Here, one point I may add while raising the dose of amlodipine, that combining ARBs like telmisartan with amlodipine reduces the incidence of edema. Next. So here I am going to discuss another point about telmisartan. So far I have not told about it. Telmisartan is effective in reducing BP. It is a RAS antagonist, so it protects the tissues and organs. Okay, but it has got certain metabolic effects, being a partial PPAR gamma agonist. So this is helpful in decreasing fasting glucose, and it is also helpful in postponement of diabetes, full-blown picture of diabetes in pre-diabetic patients. And the combination is effective, very much effective in decreasing blood pressure. And we have shown that echocardiography, it decreases LV mass index as also the diastolic function and decrease the microalbumin level. Again, this is the property mainly due to telmisartan. And amlodipine, apart from BP decrease, has shown to decrease the atherosclerosis progression in the intravascular ultrasound substudy of CAMET. So also ARBs and AC inhibitors, they are also known to be protecting against atherosclerosis. Next. So thank you. Thank you for the patient hearing. So I hand over to the organizers for next section.
So thank you very much, dear sir. Am I visible? Am I audible? For some reason I'm not visible. Thank you very much, dear sir. And I now hand over to Professor Dr. Arun Kochar, sir, to moderate the session of the panel discussion. Dr. Kochar, over to you, sir.
Thank you. I hope I'm visible and audible.
Yes, sir.
Okay, so that was very elaborative and very lucid discussion about metabolic syndrome and the drugs that are helpful for the same. We have a few questions lined up for us, and we would like to discuss these questions so that audience could be benefited by whatever we have just learned. So, and I know that time is also a concern. We are a little short of time here, but nonetheless, first question I like to ask the panel, and I would also like to, include myself in the discussion is how best we can include ambulatory BP monitoring in clinical practice, and what are the right patients for the same that we believe that they'll be benefited. So may I ask the other panelists if they could contribute to this?
Yes, sir. Sir, the classical teaching of ambulatory BP monitoring in a select subgroup of patients like masked hypertension, white coat hypertension, in patients of probably borderline stage 1 hypertension who have a high in-office BP recordings, and you want to be sure whether to start the patient on drugs, and if the patient does not have any hypertensive mediated organ damage, then I think ambulatory BP monitoring or home BP monitoring is advised. And we know that it has a more stronger prognostic indication compared to office BP recording. And most importantly, the nighttime blood pressure can also be found out in ambulatory BP measure with and also whether they're dippers, non-dippers, which also have a very wide prognostic application, sir.
So I think, I mean, you are very right, absolutely right. You have pointed. Um, um, uh, was there any other rejoinder to this question?
Yeah, actually, I wanted to add another point. In my day-to-day practice, at times I pick up those patients who are doing badly with antihypertensive, tendency to fall at night, having giddiness, dizziness. That means their daytime and nighttime is differing so much. The doctor is aggressively lowering BP, but the BP is falling more during night, particularly in early. So we have to readjust our treatment. Thank you. Over.
I think that's very apt, sir. That patients who are not being effectively treated by the current medications, then we really need to look for ambulatory BP monitoring. The only point which I would also like to add to this discussion is that Americans rightly believe that ambulatory BP monitoring is the gold standard as far as diagnosing or finding out patients who have white coat hypertension or who are resistant to treatment of mass hypertension. But Europeans believe that home BP monitoring is a better, convenient method and almost equal to ambulatory BP monitoring. Of course, I'm not going into the details and the nitty-gritties of finding which one is superior. But of course, home BP monitoring is a little convenient for the patient also. So having said that, we jump over to the second question. And second question is, just give me a moment, sir. Second question is guidelines. What are the guidelines for inclusion of ARBs and calcium channel blocker, or ARBs versus diuretics as the first line of treatment in which patients of essential hypertensions? And do we believe that patients who do not have CAD There would be other subsets of patients where ARB-CCB combination would be more effective, and why? So I initiate the discussion by saying that, chronic kidney disease is one subset where we prefer ARBs over calcium channel blockers. And they have been found to be superior versus ARB versus diuretic in subset. And as we have been rightly, learnt from the just concluded lecture, that they effectively control BP better in patients with CKD. So in accomplished trial which showed that ARB-CCB is better than ARB hydrochlorothiazide combination. Another subset where I like to use ARB-CCB over ARB diuretic would be diabetes with proteinuria and metabolic syndrome. So I think that we have also discussed. And diuretics have some side effects, and that, especially in elderly, they may cause kind of, inconvenience going to the loo more often than not. And even in patients with high sympathetic activity, ARB-CCB could be combined. So I look forward to panel to add more or, correct me if I have mentioned something wrong.
Just one point about diuretic. They are very good drug, and the multiple meta-analysis shown to be very effective, particularly lowering the incidence of heart failure. They have been found to be quite useful. Only problem happens with a country like ours. There is a lot of seasonal variation. During summer, it is something. During winter, is something. So we have to be careful and watchful during summer and winter whether the patient's diuretic dose has to be adjusted and how the electrolytes are behaving.
Yeah,
Very correct, sir.
yes, sir. And as Dr.
Please
Kocher rightly
continue.
pointed out, that probably, if you see the earlier guidelines, they used to mention as A plus C or A plus D. Then the guidelines started mentioning as A plus C as the default strategy and A plus D in a select group of patients. And these select group of patients are post-stroke, because diuretics like Profess, Progress, a lot of trials which showed diuretics are beneficial than the calcium channel blocker. So A plus D is in post-stroke subset of patients. Incipient heart failure, which rightly Das Viswas sir pointed out, and also in a very elderly patients. All the earlier trials, you name those HIVET and all those trials, basically had indapamide and perindopril studied. So in these particular subsets of patients, I think A plus D goes into the first prevalent, I mean, the drug of choice. Rest of all the patients, the default is A plus C. In fact, in the latest ESH guidelines to 2024, it is low dose triple combination, wherein it is A plus C plus D from the start, apart from a small, again, subset of patients where you don't want to give these drugs.
One point, Dr. Satur, is that those patients who are obese or overweight, they are sodium and volume overloaded. So they also do very well with low dose of diuretic.
Yes, sir.
And just to continue and finish with this question, patients with gout probably, then we may need to add diuretics in that. Another question that has come up is that patients with AF and hypertension. So how best to manage these subsets? What are the golden rules? Dr. Satur, can we start with you?
Yes, sir. I think atrial fibrillation with hypertension, we have different probably implications. The most important implication would be in the calculation of Chad's VAS score, where hypertension is 1 point, and then you decide whether the patient requires anticoagulation or not. That is number one. And number two, these patients, hypertensive patients, when atrial fibrillation sets in, they become symptomatic with heart failure. Now, this is because of atrial fibrillation, they lose the atrial booster. And in hypertensive patients, we know they have stiff ventricles, and the cardiac output also depends a lot on the atrial booster. So, patients with hypertensive heart disease, diastolic heart failure, they become immediately symptomatic with the development of atrial fibrillation, and that's again important. And hypertrophic cardiomyopathy patients, a lot of times the echo reports of hypertensive patients who are have hypertrophic cardiomyopathies are given as just cross concentric elevation. But if you see in the CHADS VASC score, the first point C is also given to HOCM even if they have with no symptoms. So I think these are few of the implications of hypertension, and of course, treatment also. You would rather use a drug which would control the rate as well as the blood pressure, which could be a non-dihydropyridine calcium channel blocker or a beta blocker. Again, is the indication as a use for a hypertensive drug. Sir, any addition, sir?
Just
So
for
summarizing what you have
comment
said,
that to reduce symptom, as you said, the precipitation of symptom, low dose diuretic may be initially required to reduce symptom. Yes.
Yes. And we
Dr.
should make the point that most of these patients try to remain in sinus rhythm. All efforts have to be made that they are in sinus rhythm.
In that point, telmisartan has got some role in atrial fibrillation also.
Yes, sir.
so even losartan has shown that it can prevent occurrence of atrial fibrillation and stabilize patients who had paroxysmal AF. And summarizing, Dr. Satur, what you said that we should concentrate on non-DHP and beta blockers. We should consider giving oral anticoagulants to these patients, and we should monitor their, progress over a period of time. So, next question, sir, to the elite panel is that how best is amlodipine telmisartan combination with early initiation in your clinical practice? Dr. Das, sir, would you like to give
No,
us some?
amlodipine is a very good drug, as I said. So either singly or in combination, we can start it, and the BP is reduced within a few days. But we have to wait before escalating the dose, because at times it takes a few weeks to reduce the BP. And very quick rising in BP, ultimately, if the patient is not recording his BP well, that a bit of low BP is presentation in the clinic. And I always advocate the monitored BP at home, monitored BP not only, but pulse rate also. And if the patient is having inappropriate control with amlodipine or having some side effect, I often combine it with a second drug or third drug, as Dr. Sattu said.
Very apt, sir. Dr. Satur, anything from your side?
Yes, sir. As sir very rightly pointed out that escalating the drugs immediately is not a very good idea unless it's a hypertensive emergency or as an urgency. These drugs require at least 2 weeks for their maximum therapeutic BP reducing level. So a very good take-home point is not rapidly escalate unless there are some indications or the patient is in hypertensive emergency, urgency, target organ damage, and others, sir.
So I think that that is very sufficient and for our understanding. Coming to the next question to the panel is the current role of renal artery denervation in hypertension, when we must use it. So initiating the discussion, I would like to add that RDN is something that is a catheter-based therapy, not available ubiquitously, but nonetheless, it is making an impact in India also. Earlier trials such as Simplicity could not prove, its use, But a recent trial such as Spiral and Radiance, kind of, modest 10 to 5 millimeters systolic reduction at systolic BP reduction at 6 months has been seen. Now, the indication, of course, is resistant hypertension. We know all what is the definition, so I won't be going into the detail. And the patient is intolerant to medication, doesn't want to take medication, and perhaps in high CV risk. So these are the setting, and it requires a dedicated cath lab with a dedicated interventionist to do it. And of course, the renal anatomy should be good, that the sympathetic chain is denerved along with the renal vessels. Anything, sir? Both panelists, would you like
I'll
to
be
add?
just brief because this subject is not for general discussion. I'll be briefly saying that RDN has shown its ups and downs. Initially, there was a lot of hype. Then it came down that this sham study has shown no effect, so it should be discarded. Finally, we are going to a balance that appropriate technology, appropriate catheter, appropriate completeness, and appropriate energy. Everything is important. Whatever has been documented that this is the technology that has to be applied, has to be applied.
Perfect, sir. Perfect. So coming to the next question, Dr. Satur, may I ask you, how do you place that beta blockers are not to be used? They are used to be in, kind of when all drugs fail, resistant hypertension. But in Indian setting, where do you place beta blocker? And also, when I'm talking of Indian, I would also take the liberty of asking, in your own personal practice, where do you use beta blockers in essential hypertension in Indian setting?
Yes, sir. Sir, if I think it was basically the Ascot trial, after which the beta blockers as the first line drugs for hypertension was downgraded, and this was basically the study. But the other side of the coin was that all the earlier trials which used beta blockers, the beta blocker used was atenolol, and it is widespreadly known that atenolol has lot of side effects, lot of metabolic abnormalities. Even if you see the life trial, all had atenolol. So that is how beta blockers as an antihypertensives are not much in vogue. But now we have lot of vasodilatory beta blockers, nebivolol, carvedilol, bisoprolol, all these newer beta blockers, which are metabolically naive. They don't have any dyslipidemic event, changes, no changes in the plasma glucose levels, and especially in our Indian subset, where sympathetic nervous system as one of the main causes of hypertension is predominant. I think it has a very promising results. We do see a lot of young patients who come with tachycardia, hypertension, of course, by ruling out the secondary causes of hypertension. In them, beta blockers, which probably soothe the sympathetic nervous system, are one of the most important drugs. These are for probably uncomplicated hypertension. Beta blockers as the indication for hypertension, we have a different sets of the indications: pregnancy, atrial fibrillation, coronary artery disease. We're not talking of that. We're just talking of uncomplicated hypertension. Probably younger individuals nowadays, a lot of combinations of newer beta blockers with amlodipine, newer beta blockers with telmisartan are coming out and are giving very promising results. So basically, younger individuals, even in women, bisoprolol in women has been shown to give very promising results. So basically, it is we use in those subsets of patients wherein we think sympathetic nervous system, they have tachycardia, or type A personalities. I think these are subsets wherein I have used and the found promising results.
So I definitely ditto what you have said, and summarizing what you said, that it was ethanol that was banished from the kingdom. But what happened that the entire beta blocker class was outclassed. So perhaps that was not right for the drugs which are so effective. I'm guilty of using beta blockers in my day-to-day clinical practice, despite the guidelines have been not in favor of them for so many years. As you rightly said, our corporate young India, which is now emerging as a superpower as far as economy is concerned, is basically based on these young Indians who have very high adrenergic tone. So this young adrenergic, India, where the targets are to be met, we need a drug for hypertension which can soothe as you said, the adrenergic tone. And I've been using bisoprolol very often in such patients with good results. One of the reasons for using bisoprolol particularly is that it has less sexual dysfunction associated with it. So I resoundly second what you have said. And if there are any comments from Dr. Das, then
Just
we'll move in.
again, to be very precise, the major points have been covered. Only a few clinical markers are there. Starting from the history, we can start about the occupation, whether he feels stressed or not, and what is the resting pulse rate, tremor, anxiety, uh, stiffness, etc. These will tell that this patient needs the beta blocker. Okay, thank you.
Perfect, sir. Perfect. So last question, and I would show my ignorance, but that I believe some of them are endothelin antagonists, and some of them could be aldosterone antagonists. So, but surely I do not know them, but of course my elite panel would like to answer them. So we have newer drugs like lorundrostat and aprocitentan and zilebesiran. So these drugs, sirs, if you would like to highlight, and then we'll wind up the session here, post that.
So with the first drug, it is available now already in India, but I think these are the drugs to be reserved. It is always better to have multiple drugs in the armamentarium so that if one drug is not useful, we can go switch over to other. And also we can have lots of permutations and combinations. From these points, the drugs in the pipeline are all helpful and they have different mechanism of action. As you said about the endothelin receptor antagonists, they are useful, and some other endothelin receptor antagonists are also useful. Pulmonary arterial hypertension. Regarding the zilebesiran, is a good drug in the point that it is injectable and has got a long effect. So those patients who are liable to forget, do not want to consume so many drugs and are non-drug compliant, often liable to forget, etc., etc. They may be, non-cooperative also. In those cases, in an injection, a few months apart, does the job. So these are the good things that we have to have alternatives. Dr. Satur, please.
Yes, sir. As sir said, the endothelin receptor antagonist, it's Trivio, which is already available, but all these drugs are reserved in patients of resistant hypertension, wherein you try A plus B plus C plus D, and probably the prazosin, uh, on all these drugs. Once you try all these drugs, and only after that, if the patient is still resistant hypertension, then you use these drugs. These are not the first, second, and third line of drugs.
Thank you, gentlemen, sirs. And I think we had a very elaborative and very detailed discussion. Most of us are wiser. Most of us would have been wiser listening to us also. Taking a leap from this, I would hand over the session back to the organizers, paying my sincere thanks and a very good evening to all. Thank you.
All also.
Thank you so much, Dr. Kochar, sir. And uh, dear audience, any good thing has to come to an end. So I'm sure we all had an academic feast, especially during the panel discussion of unfiltered opinions that followed. We take this opportunity to thank Professor Arup Das Biswas, sir, for his wonderful oration. We also thank our esteemed panelists, Dr. Arun Kochar, sir, our very own dear Satur sir, as well as Dr. Das Biswas sir, again, for the wonderful unfiltered panel discussion. We are very sure that points that were discussed in the panel, ultimately, dear audience, would help empower you to achieve better patient outcomes and treat your patients with hypertension better. So, a very good evening and wish you all a very happy weekend.
Thank
Thank
you so
you.
much.
Thank
Thank
you,
I
you.
Das Biswas
apologize
sir.
once
Thank
more
you.
regarding the initial
Thank
glitch.
you.
Sorry, Dr. Satur, I interrupted you. I was just thanking everyone and apologizing for the initial glitch.
No,
Okay.
that's completely fine, sir. It's completely
Yes,
fine.
sir. Thank you, sir.